जाना चाहते हैं?
अच्छा आप प्लीज बी साइलेंट, अब हम स्टार्ट करने लगे हैं। फर्स्ट ऑफ ऑल इंट्रोडक्शन, आई एम डॉक्टर ज़ैनब, सीनियर स्टाफ। टुडे आई विल डिस्कस जेस्टेशनल डायबिटीज मेलाइटिस। ओके, तो आपके ख्याल में कितने परसेंट पाकिस्तान में है ये डायबिटीज ड्यूरिंग प्रेगनेंसी? 70, 65 नहीं,
50 to 60%.
30 to 40%. So diabetes have all you know that diabetes have two types, type 1 and type 2. There are different terms just like gestational diabetes. Gestational diabetes when the patient entered in pregnancy without diabetes, but after a few weeks or after a few months she have diagnosed as gestational diabetes mellitus, as she has symptoms or any signs of diabetes. But if a patient is chronic diabetic, before entering into the pregnancy she has diabetes mellitus, then the treatment plan will be different. First you should know that how the patient will present. The presentation of the patient on history and examination. On history, as you all know that there will be polyuria, polydysphagia, polyphagia. These are the three major signs of diabetes, established diabetes. Polyuria means increased urination. She will awake at night 4 to 5 times during sleep for urination. This is the main sign of diabetes mellitus. Polyuria. Then polyphagia. Polyphagia is increased excessive eating. Why excessive eating? Due to increased requirement, increased insulin resistance. Due to increased insulin resistance, there is increased glucose is made by the cell. That is why patient is feeling more hunger, more her hormonal system when disturbed, there is more hunger. So polyphagia, polyuria, polyphagia, and third is polydysphagia. Polydysphagia means increased need of thirst. She will drink water again and again, and her thirst will increase as compared to the normal. These are the major signs, but most of the patients in our setup present with some different signs. For example, female present with burning sensation in the foot, with lower abdominal pain, backache and pain in the legs, with chronic fatigue. These are also the symptoms of diabetes mellitus. When a patient comes to you again and again and he or she says that I have burning sensation on my hands and numbness on my hand and I feel weakness in my limbs, peripheries, then this is also a sign of diabetes mellitus. You should work out for that. Some patients present with complications of diabetes. What are the complications of diabetes? Retinopathy,
Nephropathy.
nephropathy and vasculopathy. There will be symptoms. These are the symptoms of vasculopathy. There is numbness, there is weakness, and retinopathy there is headache and blood. So these are the symptoms. In our during pregnancy, patient present with all these symptoms if she has non-diabetic. But if she is not diabetic and you come across with the patient that comes in first antenatal visit, as in the Asia and especially in our region, Indo-Pak region, every one person out of 2% is diabetic. So we are high risk group. Then if there is family history of diabetes mellitus, if a pregnant lady comes to you and her mother or father is diabetic, then this is the second risk factor. One is ethnicity, that we are in the Asia population. Second is the family history of diabetes mellitus. Third is if she is having a child and in the previous pregnancy she has diabetes mellitus, gestational diabetes mellitus. This is the third risk factor. Fourth is obesity. If she is more than 80 kg, having weight more than 80 kg, near 100 kg weight, this is the fourth risk factor. Fifth is her obesity, hypertension. Fifth is hypertension. Hypertension is associated with gestational diabetes mellitus. These are the vice versa conditions. Gestational diabetes mellitus is associated with hypertension. So these 5, 6 are risk factors. If a patient comes to you in the outdoor or in the ward, you should take history about her personal history, what is her age, what is her weight, her family history, and her previous pregnancy history. After the calculating the risk factor, if she is having 2 or more risk factors, you will go for screening test. What is the screening test during pregnancy to diagnose gestational diabetes mellitus? Glucose challenge test, GCT or OGTT, oral glucose tolerance test. Okay, glucose challenge test is only for screening purpose, but oral glucose tolerance test is for both screening and diagnosis. So mostly we prefer OGTT, oral glucose tolerance test. Do you know the baseline investigation we offer to the patient when she comes into with pregnancy? Baseline investigation. 5 are baseline investigation. Number 1 is complete blood count, including HB. Number 2 is random blood sugar. Every patient when comes with pregnancy, you have to go for 5 baseline investigations, including complete blood count, HB, and second is random blood sugar. If she is having a family history of diabetes mellitus, or if she is having a overweight, more than 80 kg weight, then you should go for fasting glucose level or oral OGTT, oral glucose tolerance test. And this test is performed between 18 to 24 weeks. After 18 weeks, we perform oral glucose tolerance test. But in first trimester, you will go for random blood sugar and glucose fasting if there is family history of diabetes mellitus. And third investigation, baseline investigation, is urine complete examination. Fourth one is blood group and RH factor. And fifth one is hepatitis screening, hepatitis B and C. These are the 5 biomarkers. These are the 5 baseline investigation. Multiple time examiner asked from you during Viva. So you should know that. Okay. Now comes that the patient have been diagnosed with gestational diabetes mellitus. Okay. Then what effect will have on mother and what effect will have on fetus? Effects on mother and effects on fetus. First we will discuss effects on mother. If the mother is having gestational diabetes mellitus, she can have complication if she is not treated properly. Complications of diabetes mellitus are as you know, retinopathy, vasculopathy and neuropathy. Then comes the complication during pregnancy, mother's complication during pregnancy. She will have to come to the doctor's clinic more frequently than the normal patient, as she is going to label as high risk pregnancy. High risk pregnancy means there is risk during pregnancy that she will end up in miscarriage. First risk is miscarriage due to diabetes, gestational diabetes mellitus. Second risk is due to this gestational diabetes mellitus, she will have different symptoms. Just as you have said, polyuria, polyphagia, polydysphagia, dyslexia, sleep disturbances. She has more APD-like symptoms, digestion problems. All these are symptoms. And then during labor, she will have more hypoglycemic attacks. So treatment is mandatory to control the sugar level is our ultimate goal for the well-being of mother and the fetus. And fetus have more complication than that of the mother because the fetus is suffering from this insulin resistance and there are fetal anomalies. Neural tube defect due to gestational diabetes mellitus, neural tube defect, cardiac defect in the fetus. Number 2, cardiac defect. First is neural tube. First is miscarriage, then neural tube defect, then cardiac defect, then comes about macrosomia, large for gestational age or good size baby, and then comes polyhydramnios. Polyhydramnios is excessive water around the fetus, and these all complications occur when there is no control over gestational diabetes mellitus. So the question is, how will you control gestational diabetes mellitus? Anybody?
Yes, ma'am.
How will you control? Yes.
Ma'am, first dietary changes and exercise.
Yes.
Then medication will ma'am.
Dietary changes and exercise. How will you counsel the patient about dietary changes and exercise?
Low carbs intake.
Low carb intake.
And exercise, ma'am, उसकी जो है ना depend करता है मैम कितनी exercise मारनी है.
Exercise during pregnancy is allowed, but no heavy exercise.
Yes.
She can walk. She can have stretching exercise. She can have meditation or aerobics, but swimming, jumping, this is not allowed. Okay? So heavy exercise is not allowed during pregnancy, but walk for 30 minutes after every meal. Stretching exercises, these are allowed during pregnancy. Okay? So you will counsel the patient about dietary advice and exercise first, number 1. Number 2,
medication is
Medication.
insulin.
insulin.
Yes.
Insulin is recommended, but you can start with oral hypoglycemic agents. Metformin. Metformin is safe, and it has been proved that metformin is easy to take, and patient can go home with metformin, but regular check of glucose level is mandatory. So you will counsel the patient if the oral hypoglycemic will not work and your sugar is not controlled up to the maximum dose of oral hypoglycemic agent, then we will shift the patient onto the insulin. There are different types of insulin. Do you know the types? Regular insulin, NPH, rapidly acting insulin. Yes. Mostly in pregnancy we used to give regular insulin. 3 times a day, regular insulin with 3 meals. Okay? So these if the patient comes to you with a high level of glucose like 300 or 350, first you will involve the physician. As we are working in the tertiary care center, multidisciplinary team involvement is very mandatory. Whenever you will come across with this patient, and say for if you are going to give exam and your long case is about gestational diabetes mellitus, you have to tell that I will involve multidisciplinary team for the management of this patient. Your examiner will ask the question, how will you manage this patient of gestational diabetes mellitus? If you will say that I will manage it by you, no. You will say I will manage this patient by involving the multidisciplinary team, and you will pass by telling only one point, that I will involve multidisciplinary team. I will involve physician for the dose adjustment of insulin and for the good control of sugar. Okay? And with the help of physician, you will control the sugar levels. And in the ward, when the patient is admitted, how will you monitor the patient? In the ward, when she is admitted, you will monitor with 6 levels. Fasting, 1 hour after breakfast.
Yes.
Before we will go for 2 hours after breakfast. Now 1 hour. 60 minutes to 90 minutes are the maximum time for the insulin spike. 60 minutes to 90 minutes after eating anything. So we will go for after breakfast level, first before breakfast, fasting level, then after breakfast, then before lunch, then after lunch, then before dinner, then after dinner. You got my point? In the ward, patient is being admitted for the monitoring of the glucose and management of the gestational diabetes mellitus. You will say to the examiner, I will go for 6 levels of glucose monitoring. Fasting, after breakfast, before lunch, after lunch, before dinner, after dinner, or at bedtime. Okay? These are the 6 levels, and when these 6 levels are being monitored and well managed, patient level are being controlled, then we will discharge the patient. Otherwise, we will not discharge the patient, as high sugar level will directly affect the growth of the fetus.
Yes.
So the patient being admitted here for many days, for 2 weeks, 3 weeks, till their sugar is being controlled, then we go for discharge of the patient. And the counseling of the patient is very important. Once the patient's sugar level has been controlled, she asks again and again that I have to go home, I have to see my kids, and I have to do this, and you have to counsel the patient that this baby will be affected badly if you will not control your sugar at home. Before going to home, you have to counsel the patient that sugar control is very necessary for the survival of this fetus that is coming out. So your counseling is very important. Patients usually take not seriously. They say that this is a normal thing. Sugar and hypertension, they don't bother it in our circumstances, as the patient have very less knowledge about the complications. So you will have to tell each and every complication to the patient. Yes. Yes.
And do we have same criteria for glucose की जो levels हैं as normal person? Like for fasting, there is about 110 हो तो हम कहते हैं sugar है. तो pregnant woman भी ये होगा.
Yes, there is criteria according to the NICE guideline, according to the WHO guideline, and you have to memorize this criteria as this will come in your MCQs. Now I am going to on this topic. According to the NICE guideline, 2015 की ये guideline है और उसमें वो कहता है कि आपका fasting glucose level should be more than 5.6 millimole. Fasting glucose level should be more than 5.6, and 2 hour postprandial glucose should be 7.8 millimole. This is the OGTT criteria. But WHO has less values. WHO criteria is fasting 5.1 millimole and 1 hour of post 75 gram glucose load is 10 millimole and 2 hour is 8.5 millimole. Now we recommend WHO criteria as this is the latest criteria. WHO criteria. Then comes the 5.1 to 5.3 fasting and the 7.8 is after lunch. Millimole per liter. Because in our setup we used to say in 200 milligram, but in international units you have to memorize this. 5.1 millimole fasting and 7.8 millimole per liter post-prandial or after lunch. Then we were discussing the effects of diabetes on pregnancy. There is increased risk of miscarriage, increased risk of congenital malformation, increased risk of preeclampsia and hypertension. Then increased risk of stillbirth when the baby is full blown. Due to polyhydramnias, due to macrosomia, there is increased risk of stillbirth. There is increased risk of intrauterine death, demise of the baby. Increased risk of infection to the mother as well as to the fetus. Increase operative delivery risk. Why? Because of good size of the baby, normal delivery will be difficult. There is risk of shoulder dystocia, there is risk of maternal perineal injuries, perineal tear. So there is risk of operative delivery during if the gestational diabetes mellitus is not controlled. Even polyhydramnias and macrosomic baby are two indications of C-section, as they will end up with complications during normal delivery. The most important thing is to the mother is risk of hypoglycemia. When she is taking oral hypoglycemic agents or she is taking insulin, you should know very well that hypoglycemia is less dangerous than that of the hypoglycemia. Hypoglycemia can be life-threatening. When the sugar is low than that of the normal, patient got dizziness and she faints. And if there is nobody around her, she can be have death if she is not resuscitated. So hypoglycemia is more dangerous. Remember, hypoglycemia is more dangerous. So you have to counsel the patient about the signs and symptoms of hypoglycemia, and she should have a candy or some sweetener with her every time. Whenever she feels dizziness, she feels headache, blurring of vision and tremors and low energy, she should take some sweet, some candy, some sweet fruit like banana, like honey. So the hypoglycemia should be corrected immediately. When the sugar level is below 60, patient got symptoms of dizziness, tremors, low energy, weakness, and when the sugar level is below 50, she got faint. And when the sugar level is below 50, she can die. So you should counsel the patient when she is taking treatment that these are the signs of hypoglycemia and you should take some sweet when you feel these signs. Okay? These are signs and symptoms. Then there is increased need of folic acid during first trimester to prevent the reproductive defect in the management of the gestational diabetes mellitus. You will give double dose of folic acid when the patient is having gestational diabetes mellitus and having chronic diabetes mellitus. So So folic acid 5 milligram is recommended in active form. And you will monitor the patient for hypertension as well. As I have said that gestation diabetes mellitus is associated with pregnancy-induced hypertension. So you will monitor the blood pressure of the patient regularly. You will monitor the urine for albumin regularly. You will, if the patient is treated with uncontrolled gestation diabetes mellitus, you will involve ophthalmologist, eye specialist to check about the retinopathy. So the patient complications should be addressed and should be managed timely. After delivery, when the patient is in labor, you will monitor the sugar level and you will give insulin. After delivery, how will you know that this was a gestational diabetes mellitus or a chronic diabetic? How will you monitor? After delivery, the sugar level will decline and patient will get normal sugar level. This is called gestational diabetes mellitus. But if after 6 weeks of delivery, patient still have high level of the glucose, serum sugar level are high, then you will label her as chronic diabetes mellitus, because her level did not decline after 6 weeks. So you will monitor her till 6 weeks after delivery about that to label her as chronic diabetes mellitus or gestational diabetes mellitus. So after delivery, you will counsel the patient to come back and come with the level of the sugar. Then comes how after delivery immediately how we can monitor this after immediate delivery, how we can monitor the serum sugar level and how we will neutralize this sugar level, because during surgery or if the patient goes to went into C-section, then her sugar level, she is NPO, she is not taking any glucose, she is not taking any diet, then her sugar level due to surgery, her sugar level is 300, 350, then you will give her neutralizing drip. We give her glucose with insulin in the drip form, or we will give her not give her 5% dextrose water, only ringer lactate, and a different solution has been given to the post-operation. So if you want to maintain the sugar level of immediate postpartum female, you will advise her early breastfeeding. Due to early breastfeeding, the sugar level is maintained. Second, you will advise her to walk after delivery. She should walk, she should mobilize early, she should breastfeed early, and she should be NPO, her NPO should be break early. When she will after C-section, say for she have been given anesthesia, spinal anesthesia, you should break her NPO early after 12 hours. You should start breastfeeding, encourage her to start breastfeeding early, encourage her to walk early. These 3 tips will maintain her sugar level immediately after delivery. Yes. So the 2 tests you will ask to the patient after delivery after 6 weeks. One is serum sugar fasting, and the second one is HbA1c. Serum sugar fasting and HbA1c will diagnose that the patient is gestational diabetes mellitus or chronic diabetes mellitus. Any questions?
Should we take any precautionary measures for the fetus as well, or it will be okay if we control the mother's diabetes only?
Repeat, Karan.
Should we also have to take the protective measures for the fetus as well, or it will be okay if we only control the mother's diabetes or sugar level?
Yes, if you will control the mother level, then it will be okay.
Fetus to hypoglycemia.
After delivery, you will check the serum sugar level of the fetus, and if the fetus is having hypoglycemia, then we will give the glucose to the fetus. 25% के तक drop हम उसको देते हैं. ठीक है? और कोई question? Thank you.
मैम सेव हाईलाइट
हैं ये लॉक क्यों हो गए
पहले ही था
हैं
diet